Good evening, everyone. It's 6 o'clock. I'd like to call the meeting of the Macomb County Community Mental Health Board to order. And before I do, I'd like to read our mission. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. Motion to adopt the agenda is in order with two changes. One is we want to remove 6A because it has not finished its review by Corp Counsel, and to add 10B, which is a chair's report from the conference.
What's the number of that again?
We're removing 6A because it has not completed review by Corp Counsel. We're adding 10B, which is the chair's report from the conference.
What's 10A? Shares.
10A will be the management report.
I would so move the amended agenda.
All right, motion by Lou, support by Flynn. Okay, first item is hearing of the public. Is there anyone from the public that would like to address?
You need a vote?
Oh, why don't we vote? Yes. A vote to approve the agenda. All in favor signify by saying aye.
Aye.
Opposed? Thank you. Next is hearing from the public. Anyone from the public that would like to address this body? Anyone from the public? Seeing none, we'll move on to item number 4A, which is the minutes of the regular board meeting that was held on September 26, 2018. Motion by Bush, supported by Doherty to approve the minutes. Any discussion on the minutes? All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is approval of 5A, approval of the standing committee meetings of program and budget that was held on October 10 of 2018.
Support.
Motion by Doherty, supported by Flynn. Any discussion on the minutes of program and budget? All in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is minutes of the Recipient Rights Advisory Committee that was held on October 15, 2018.
Move to approve.
Motion by Flynn, supported by Selena. Schmidt, any discussion first? All in favor signify by saying aye.
Aye.
Opposed? The minutes of the Recipient Rights Advisory have been approved. Next, we have item 6B, which we discussed at our item category 6, B, C, and D. All of these were discussed and approved at the prior program and budget meeting.
Move to approve B, C, and D.
Motion to approve item 6, B, C, and D by Flynn. Support by Schmidt. Any questions or discussion on those three items? Okay, all in favor signify by saying aye.
Aye.
Opposed? Motion carries. Next is a motion to receive and file the revenue projection update that also was reviewed at the full board, or at the program and budget meeting. Motion by Birdie, support by O'Connell. Any questions or discussion on that? All in favor signify by saying aye.
Aye.
Opposed? That also has been received and filed. And there are no resolutions tonight. All right. The next is one of the big things we're charged with doing, and that's approve the list of bills. Motion by Birdie, support by O'Connell to pay the bills. Any questions or comments about the list of bills? All in favor signify by saying aye.
Aye.
Any opposed? Motion carries. Bills have been approved. Next is the management report, and we have our Deputy Director, Jim Losey, to give that tonight.
Thank you. First of all, a number of items for your calendar. On Wednesday, November 7th, program and budget meeting, 6 o'clock here. Metro Region Dinner is going to be held, hosted by Detroit Wayne on Thursday, November 15th. Location yet to be determined. I'll get that out too.
First date you gave, could you say that again?
First date, November 7.
And it's what?
That's program and budget. 6 p.m. here.
Which is a week earlier than usual.
Thanks.
Then the Metro Region Dinner, November 15th. I believe will be at 6 o'clock, and locations yet to be determined. We'll get that out as soon as possible, as soon as we're informed. And then full board will be Tuesday, November 20th, which is the week of Thanksgiving. We usually do that a day earlier to allow folks for prep on the Wednesday before Thanksgiving. So that's on Tuesday, 6 o'clock here. On Monday, beginning Monday, recipient rights assessment, October 29 through November 1. We expect the exit conference will be sometime late morning on Thursday, the 1st, November 1st. We will get that information out as soon as possible.
Can you repeat that, please?
Recipient rights assessment will be October 29 through 11/1.
I think we were just looking for the exit conference.
Yes, it will be held on Thursday, November 1st, but we don't know what time yet. That's usually determined depending on how fast the reviewers are moving along.
But we don't know the time and place.
We don't know the time and place. It'll probably be at admin, but we don't know the time yet.
November 1st.
And as far as an entrance conference, I know there were some questions at the advisory committee the other day. I spoke to Mark, and he said that he received from the department that they no longer hold a formal entrance conference for the assessments. However, they want to meet with Mark as rights director, John, and any other persons we would like to have present for an informal meeting at 9 o'clock on Monday morning. So it's not a formal entrance conference, but they're hosting or having a informal meeting on the 29th at 9, if anyone wishes to attend. Correct.
But they're not looking for any board members to be there.
They're not.
And if no board members show up, that's fine with
That
them.
would be fine, yeah, they're not soliciting board membership in particular, no.
Okay.
Oh, the 29th, we have, Madam Chair, 29th, we have, interview.
Right, but that would be in the afternoon, I believe, right?
Okay, the State of the County address will be held on Wednesday, December 5th. We believe at 6 p.m., however, we don't have a lot of details on that yet, but as soon as those are available, we'll send them out. The MCCMH Holiday Open House will be Thursday, December 13th, from noon to 5 p.m., kind of a save the date. As you might know, for the last several years, we've kind of scaled that back pretty dramatically in terms of the expenditures on that. I would expect that this year will be the same, just very light hors d'oeuvres and.
Is that the same day as program and budget in December?
Yeah, at 6 o'clock, CMH.
So you're going to have the Christmas gathering, the afternoon of program and budget.
Pulling up-
Budget's on Wednesday,
Pardon?
on Wednesday,
Oh, we have the 13th.
He said Thursday to 13th.
is for the party,
Right.
Yeah.
but the program
And
budget.
program and budget
It's
is
the
also,
13th.
I have it 6 p.m. that time. I don't know for
Wait.
what reason.
Just a minute.
Oh, was that an adjusted date?
Wait, just a minute, Commissioner Kraft?
Yeah, that's an adjusted date because on December the 12th, there's a Board of Commissioners meeting at 5, a swearing-in ceremony at 6, and then the meeting following at 7. So that's why we adjusted it.
Right, so,
Program and budget was moved from Wednesday to Thursday earlier.
right, so we can go to the holiday event earlier in the day and then come to program and budget if you want to do both in the same day.
Is there a chance of moving it to the CNC or that's?
You're kidding, really.
I'm not kidding.
What time is the holiday?
It starts at noon,
Noon to 5.
noon to
Yeah.
5.
And then we would, at the same facility, have our program and budget meeting?
No.
Not usually.
Not usually, it's, no, program budget would be held here.
May I suggest that we consider moving the holiday date?
I can check to see how far along they are as far as invitations. I don't know that anything has gone out
We're supposed to go out next week.
next week.
What- I think we can handle both of them,
Mhm,
yeah.
Okay.
We got plenty of time in between. Maybe another option might be to change the location, you know, if that's a doable thing, we could maybe look at that. But that might not work out either, because it would be the same room, it'd be the same room.
Right.
All right, yeah, continue, Jim.
Okay. And then also, we have board work group meetings scheduled the first on the 30th, next Tuesday, at admin at 7:30 in the morning.
Work groups.
Work group, yes.
Which I think we had a prior email about those dates too, to save those dates, so. Right.
Okay, that's all I have for the calendars. I do
Alright.
have a report I would like to provide you. If you'll recall, back in May, we presented and the board approved a data project with AFIA, and I would like to provide the first quarter update report from that contract. This is a fairly lengthy report and summary, but I wanted to make sure that enough information was provided so that you could understand exactly what we're doing, where we're going up to this point, and what the future plans are for use of the dollars that were approved for that contract. So if we could run through this fairly quickly, and please feel free to ask questions as we go along. The first part, summary of quarter one progress, details, and focus areas for the next quarter. Page 4. This was the item that was in the actual contract language where we talked about goals to try to achieve by the end of the first quarter. And they were, as to be reminded, by the first quarter of the project, AFIA estimates that total fees will accumulate to approximately $60,000. During this period, we spent $42,000 against that $60,000 goal, so we came in under that projected amount. At that point, AFIA predicts that several quick win changes will be in place in adding value to CMH. I think there will be some evidence of that, and we'll go through that as we go through the presentation here. At that point, AFIA will be able to estimate projected return on investment. We will also see that as part of this. And also by the end of quarter one, AFIA expects MCCMH to be transitioned to the AFIA Analytics platform. That has happened. We are continuing to work with them to build the information that's available within that platform and get it out to as many people as possible so that they can have continual and timely and up-to-date as possible access to that information. So the next page, number 5, focuses on what we've been really looking at for the first quarter of the project timeframe. Contract was approved and really kicked off in June, and we started to have project meetings where we identified protocols to move forward, how we were going to address various questions, trying to identify various questions and that required answers, and looking at the data in order to hopefully provide answers to questions that had been posed by the various groups that were working with AFIA. In July, we had a data mining meeting where a number of staff sat around and reviewed the data related to hospitalizations. We would pull up various aspects of admissions, length of stay, continued stay reviews, various aspects of the clinical portion of the hospital stay. And one of the things that we were looking for is what kinds of things are we able to access in terms of data, and what does that data potentially tell us? So we were kind of brainstorming a number of areas that we were looking at to say, okay, based on what we're seeing in this data, are there targets that we can identify in order to try to save dollars against our expenditures on inpatient hospitalization. Once we did that process, one of the things that AFIA did almost a little bit behind the scenes was look at data cleanup. We were identifying a number of things as we were looking at the data, excuse me, that at times just didn't seem right. We were recognizing that some of that data might have been inaccurate within our EMR. One of the areas that we'll highlight in here was related to the number of, we tried to find out how many people do we have inpatient hospitalization at any given time. We were not able to get a firm number on that, and as we were looking at that, it was because some of the ways we were recording the disposition of the hospital requests was inconsistent, as well as the hospital providers were not always providing us with a discharge continued stay review. So somebody might be discharged from the hospital, we would not get notification, so we would think that somebody is still in the hospital. We started to identify that, wait a minute, as these hospital length of stays seem to be getting longer and longer, it's like, wait a minute, that's not reasonable that somebody would be in the hospital that long. So we started looking into them a little bit deeper and identifying that we're not getting hospital discharge information on some percentage of admissions. So that is something that we had to go back and clean up a little bit in order to have better data. Then we also did identify, as we were looking at the information, that we started to recognize that when somebody contacted the Access Center for a request for inpatient admission, that if those requests came in by telephone, which was the circumstance in non-contracted hospitals, as opposed to coming in electronically for contracted hospitals, we started to identify that the admission rate was lower for those that had a telephonic review for inpatient admission. So we said that admission rate looks like it's about 43% as opposed to 67% for a admission request that's coming in electronically. So we've started a pilot, and it actually kicked off earlier this week, to work with local hospital, St. John, to do their CONs, their certificate of need requests, telephonically, so that we can have that interaction with staff at the hospital and hopefully make better decisions for both of us related to whether that consumer actually needs hospital care or not. So that's one of the hypotheses that we're testing as part of this, and it was identified as through an opportunity to look at the data kind of in whole and do some mining and digging in and finding out, okay, what is this data telling us? On page 6, the next page, you'll see that we have had a change in the projected cost for hospitalization. It looks like this year we're going to come in about $475,000 less than we did last year with regard to inpatient services. So what we did was to take that amount of savings, the reduction be $475,000. The cost of what the AFIA contract was, which is $42,000, and then we recognize that we can't attribute the entire reduction to just the data. Staff have to be involved in making decisions around length of stay and admissions and those kinds of things. So staff had a significant impact in terms of the reduction of the inpatient dollars. So we took half staff cost and half contract costs, reduced, and so the cost of investment being $84,000, we came up with a 465% return on investment for what we paid out during that quarter one time frame. So we were able to demonstrate that in fact we were able to get some savings via a analysis of the data, and this only takes into account part of that data, because we will also likely see some savings related to the telephonic pilot, as well as some other things that we're looking at related to hospital admissions and length of stay. And we'll talk about length of stay in just another minute. Other quick wins that we've identified here, that for August was the lowest number of hospital days that had been authorized since February of 2015. So we have seen a significant reduction in the number of authorized hospital days between then and now. And part of that at least can be attributed to the availability of this data and being able to look back at it and make better decisions based on the information that we have. The center box there on page 7 is this is related to the telephonic CON pilot that we're looking at. For contract hospitals, the admission rate was 68%. For non-contract, it was 58%. And so we wanted to look again at what's the impact if we do more telephonic screening as opposed to electronic screening. Can we replicate that across other hospitals? So doing the pilot right now to see if that pans out, and if it does, we will expand that to other hospitals as well. And then the third box there is data cleanup, and we talked a little bit about that. The data that we were identifying through pulling the information from the data warehouse was that we had about 225 consumers inpatient at one point in time that we were looking at it. So that was the number of consumers that we thought we had inpatient based on the information that was in the EMR. When we finally got into cleaning up the data, we identified that real number was more like 100. So a significant difference in terms of the number of folks that were in the hospital. And we can, with the data warehouse, we can look at that, we can pull that 100, and then we can drill down to the actual consumer level of who's in there, and we can figure out how long have they been in there, how much does it cost, and why are they still in there.
We weren't paying for the 225, but
no.
we're still only being billed for the 100, but at a given time, we didn't know
That's
what
correct.
that was looking
Yep,
like.
that's
Okay.
correct.
Commissioner Doherty?
Thank you. Sorry, but it does say it could lead to incorrect billing, right?
Yes.
So does that ever get resolved and corrected, or?
Well,
is
part of the problem is if we don't get a discharge CSR from the hospital, we don't know the exact discharge date. Now, if in fact the hospital does bill for only the days utilized, we're fine. But we have no way of knowing that without the discharge CSR. So that's where I think the improper or incorrect billing can come in, is if that hospital were to bill for more days than they were actually there, we have no source of truth to go back to and say, no, wait a minute, the discharge was this date versus that date.
So do we have any mechanism to say we're not going to pay a bill until we have a discharge date, so that we know that the billing is accurate?
We are moving toward, that's in the contract right now, and we are moving toward enforcing that to make sure that we have that CSR before any dollars are paid.
And will there be any audit to go back and get discharge dates for past billing to see if we have been overcharged?
We would certainly like to do that. We will need to assign some resources to doing that, and
Yeah, I mean, I think we definitely need to do that because, it's feasible that we could have inaccuracies there and we could recoup some serious money that way.
Right.
So, okay.
Okay, page.
Comment to follow up on that. The county has used to do that with just the regular Blue Cross claims. It was a definite return on the investment because the additional resources we paid to have that audit done more than paid for. We had returns on that and made money, came out ahead. And it kept getting smaller amounts every year. Last time I was there, they weren't doing that anymore. I don't know if they picked it back up again, but that's how well that helped to keep the billing in line.
Okay, thank you.
One of the things that we do on a regular basis is that Medicaid verification audit. Anything that's being paid for by Medicaid dollars, and off to see if hospitals are in that rotation for a review of those inpatient services. If they're not, there might be something that we could add to that in order to have that reviewed. Okay, page 9. Results in 3 key areas. We are seeing improved outcomes. We're targeting issues in ways that we couldn't target them before. I think the telephonic CON is a good example of that. The ability to recognize that, in fact, we do have a differential in terms of the inpatient admit rate based on the methodology of that CON being communicated to Access Center and the amount of information that they have in order to make that approval. I think we get better information when we have an opportunity to dialogue with the staff and talk about symptoms and plans and what things have been tried before we go ahead and approve an inpatient admission. Evidence being the total days decreasing as a result of Access staff viewing and taking action on data on a routine basis. Data problems that were unknown for years coming to light. The hospital discharge date question that we talked about in terms of knowing how many people are in the hospital at any given time. And decisions are improving. Decisions are faster at the same or higher quality. When one hospital that we had approached had opted out of the pilot discussions, we were able to look at the volume of inpatient requests instantly to determine, okay, where else do we go in order to identify a pilot location for the telephonic review study. Page 10 is an interesting one, and I think is very illustrative of what we've been able to achieve so far. When we started the project, the average length of stay was 7.35 days, and that was as of June 1, 2018. If you look on the graph, back in November of 2017, we had a peak of length of stay of 10.9 days. As of when we pulled this report, end of September, our length of stay was 5.97 days. So we've had a significant reduction in the length of stay, and if we're able to safely move that consumer out of the hospital 3 days early, we're going to see a cost savings related to that, and that's where I think we're seeing some of that $475,000 reduction in the projection for this past fiscal year in terms of inpatient hospital stay expenditures. Interestingly, if you look at the graph and the arrows that have been highlighted here, the original dashboard training was provided to the Access Center when we had the AFIA contract operating under our technology grant funds. In January, we did a training with the Access Center staff with regard to using the dashboard and using the information that was available to them. And you can see between the time frame of 12/17 to of January 18, that length of stay dropped from 10.57 to 8.67. So just the ability to access that data and having that knowledge kind of at their fingertips, we were able to see a reduction in the length of stay pretty quickly. And then the other data point, the Manage Analytics start, as of June 1st, 2018, we were at 8.49 and have dropped down now to 5.97. So again, the ability to access that information, have training on what that information means, and be able to have that basically at your fingertips as part of the data warehouse and dashboard has been significant in terms of the length of stay.
Susan?
Thank you. Yeah, I mean, this is good. I mean, these are good numbers to see and some things that can really point out some differences. So I would say that the next step on this chart is to add a benchmark to our peers to see what our neighboring counties are doing, because even though you've made steps in refining, the review of the records, I wonder if there aren't other practices among our peers that could drive that down even further, or if we could leverage resources across other counties, if we have hospitals that maybe are not participating in the pilot and you have to find, maybe we can partner with some of our neighboring counties with facilities that are close enough in proximity or whatever.
Right.
I mean, it just seems to me that seeing this trend, that I wonder if there's not even, the improvement is great, don't get me wrong, but I'm wondering if there's not ways to really even drill down further.
Right.
If you benchmark it, right?
Yep, I think that makes a lot of sense. We will do that.
Does AFIA serve other counties?
They do. I don't know that they serve anybody in our immediate region.
Okay. So it would be interesting if they serve even any other counties. Let's do some benchmarking data with those, but then maybe this is something we can share.
Right.
And then we can all find some efficiencies and leverage across each other. It might
Right.
be worthwhile to share this data point.
Yes.
Okay, thank you.
Thank you. Okay, on page 11, uncovering bad data and changing systems. Previously, we had no way to track diversion barriers. We couldn't identify whether someone was hospitalized because a diversion was not available or whether they were not appropriate for a diversion. So this gives us information that helps us identify what the capacity of these diversion services are, and whether that service is available in our disposition categories for the CON. I believe we've added a data point that says that a diversion was not available, as opposed to whether that person was appropriate for a diversion or not. So I think there's two different pieces of information you can glean from that is, if there was no diversion available, do we need to increase our diversion capacity in order to divert more consumers from inpatient hospitalization? For certificate of need, the CONs, without authorization and without discharge CSR, we're throwing off our length of stay data. We've had an effort ongoing to clean up that data for a couple of months now, and it is getting much, much cleaner. And then, as we've talked about, discrepancy in the discharge date on the discharge CSR made it hard for us to identify how many people we have in the hospital at any given time. This is actually just more detail related, and it's very, very difficult to see. I recognize that it did not copy in a format large enough to really identify what's on the graph. But this basically was what led us to implement the pilot, that we were recognizing that non-contract hospitals had that lower admission rate than contracted hospitals, which were doing it electronically. So that pilot began early this week. A little bit too early to have any data related to that, but we will bring that along as we get it.
So it appears that the contracted ones are all telephonic and the others were electronic, or that's not?
Other way.
The other
Yep.
way. So do you have the ability to do the, to do the telephonic with the contracted ones?
We do. We would have to add
Okay.
resources to the access center in order to do that. And
Okay.
it's a little bit more resource intensive to be on the phone with somebody than to, receive a electronic CON and then review it kind of in between other things. But yeah, we would have to add some additional resources, but depending on what we find, it may very well be worth it to do that.
Thanks.
The other piece is,
Sorry, yeah,
sorry.
on that same point, sorry. So it makes sense to me what you're saying, that the telephonic, like if somebody calls in, we have to have somebody that's gonna be able to answer their phone. So are there high level, I imagine there are high level steps that happen that are relatively simple, check here, check there, data point type things. But then, once it reaches a certain point, it gets a little more complex, right? So is there a way to divide those steps and think about how we could systemically address maybe those first few steps that are a little more routine and repetitive? I'm making this up because I certainly am not an expert in the field that you're talking about, but let's say there's, several hospitals that would be the first place that a person would look to see if there's diversions or see if there are beds or whatever the resources that they need. Well, if you could systematically be receiving data about that availability, you could automate that, those first few steps, right? Which would then free up the staff that would ever take that to do the more complex
right,
things. So keep that in mind before you think about an additional staff.
Right.
Think about how you could automate those first few steps. I mean, like I say, it's going to be difficult to, you could never automate the whole thing because
Right.
it needs human intervention, but there are probably, the first screener of the calls would probably do, steps 1 through 5. You might be able to automate 1 through 3.
right.
and then divert the staff to the more cases that need more intricacy.
Yeah, okay, I made a note of that, we will definitely look at that. And one of the things that I think we'll get to in the report yet is that part of this, you might recall, contract included subject matter expertise, and we have a former staff person from Livingston County and also Washington County that works with AFIA that has worked with us at length regarding the open access project that we've got going. And she has experience, nationally from National Council and from SAMHSA and a variety of consultation engagements with other like systems. And so she's been able to provide us with a lot of ideas and the ability to bounce things off of her and to identify pitfalls or pros for some of the ideas that we may have. And so this would be, I think, a very good thing to put out there and say, well, is there a piece of this that we can automate in order to collect that information ahead of time and then follow up with the telephone call related to the specifics around the request for hospitalization. Yep.
I'll just say it here instead of at the end. So all these, all this ability to see maybe excess hospitalizations or stays or whatever. The bottom line are the people being diverted to a better situation or just diverted. That would be important to me to know that
Right.
not just that you're saving hospital days, but you're improving the outcome for them.
Yeah, you're absolutely right. I mean, inpatient hospitalization is a level of care that when somebody goes into the hospital, it tends to be traumatic for them. It tends to be something that is very challenging for someone because they typically, when I was case managing, I had folks that were in apartments, and someone went into the hospital. They often lost that apartment, they lost their car, they lost their job, they lost all of their belongings. So it's a very, very difficult situation for consumers. So if we're able to divert somebody and it's safe and it's appropriate, I think that's the much better outcome than somebody going inpatient. But if somebody absolutely needs the inpatient level of care, we need to be able to provide it. I agree.
So I just want to make sure that we would keep that in mind and look at that,
Yes.
the data on that end of it too.
Right.
Thanks.
Okay, then on slide number 13, data analysis is not just for IT. This really speaks to the a little bit of a change in the culture that we have around CMH in terms of looking at data and information to support decision making. And I think it's very critical that we look at that and be able to say, if we make this change, how will that likely impact our bottom line as well as the consumer care? And I think both of those are very key pieces of the puzzle. And this really gives us the piece that we didn't have, that data that says, okay, if we make this change, this is what the result to the system might be in terms of utilization and then hence dollars. Making decisions with confidence.
Sorry, this is
Okay.
kind of,
Yeah.
this is kind of, data, I love data. So how, as you're building this, kind of dovetailing to what Linda was saying, how are you thinking about how to track the quality? Like, I mean, there are ways to track the quality of, you can look at, recidivism rates, you can look at, you can do some surveying of the consumers to see how they were treated. You can track, you could track success rate by vendor, wherever they were served. I mean, to track the quality. To Linda's point, to say, it's great if we can save, 2 days on an admission, but it's even better if we can save 2 days on an admission and reduce the recidivism rate, right?
Right.
I mean, because that's better for the consumer, because then they have a higher
Right.
quality outcome. So are you guys tracking, are you building that tracking mechanism in as you build this?
Right. We have, quality is heavily involved in the planning for all of this. Right now, we're really focused on data and being able to get the information that we need to support the decision you're making. I think the part of the quality piece will be reflected in our KPIs, which is our key performance indicators, and recidivism is one of them. Length of time from call to onset of service, length of time from call to assessment, and then assessment to service are areas that we're tracking. And so we're paying a lot of attention to those things and trying to, one of the projects we've got going with the FIA right now is to reduce anywhere we're not meeting that set of KPIs, and those are all really quality indicators of one type or another. And we're looking at saying, okay, let's eliminate all of these non-compliant KPI data points. We want to get to a point where we're performing at the minimum state level or exceeding that on each one of them.
Okay. And then, you had mentioned about diversion where you're indicating if there was no diversion available, but are you gathering a data point as to what type of diversion that you would have wanted but isn't available, so that then we can very specifically increase that particular type of diversion?
Correct, yes.
Because you said that you're tracking if no diversion was available, but
Right.
my thing is if I wanted this kind of diversion, I want to know what kind of diversion wasn't available, so then you can track your volume of need. Then you can
In that
target
particular
which
area.
vendors have your best KPIs, and then you can increase that vendor's contract and get lower unit pricing because you're sending volumes of business, right? I mean, there is a method and a science to it, right?
Absolutely, yes. And I can't speak definitively to that we are tracking the type of diversion that they were seeking. It would be available in the record, but is it a data point that
You
we can
gotta have
pull
a
out?
data point,
Exactly.
because otherwise it's
Yep.
not any use
Yep.
to you.
I
mean,
would be
it is for
surprised-
the individual, but not for the volume that
Right.
you're tracking.
I would be surprised with what I've seen with the FIA that they would not have built that in, but I will double check it.
Okay, yeah, because that's, I just had made a note there, but that's something that I think is very important, so we can select vendors properly.
Okay.
Thank you.
Yep. Page 14, making decisions with confidence. This speaks to the subject matter expertise that comes along with the contract. We've been working with Kathy on the open access project in terms of how do we structure that program to make sure that we are running that as efficiently and as effectively as possible. Right now, we're really working with her to define at what points does it make sense to collect the various pieces of data. One of the goals being that we want to reduce redundancy. We don't want the consumer to have to tell their story twice, once to the access staff and then again at the point of intake, and also make that each contact more engaging and more welcoming to the consumer so that we get better results in terms of our no-show rate, whether we can reduce that because we've got better engagement with the consumer. And through lots of discussions with that subject matter expert, we've had hours of discussion with her in terms of what is the best way to proceed, and she's been able to provide her expertise and direction in terms of how to maximize the benefit for what we're trying to accomplish. Focus areas for the second report period for quarter 2 on page 16. Open access as a managed analytics initiative. We're using data to determine whether that program is being successful. We're developing, and I think they have a separate work group that's working on metrics related to open access, how many no-shows we have, how many people are coming in, those timeframes related to referral from the access center to somebody actually accessing services, time from the call to the walk-in assessment. Start of the phone authorization pilot, success metrics being lower admission rate, total hospital days reduced, increase in diversions from inpatient admission, and neutral cost impact considering the staff time that would be involved. As we point out here, I do believe that we'll see a positive cost impact that will be return on investment based on what we've seen already so far. And then other areas that we're looking at, access manager supervision in terms of what decisions are being made at the access center level, informing the supervisors to be able to do better supervision with regard to our decisions being made at that point in time that are appropriate for the consumer. So an ability to go back and look at decisions that were made, review those with the staff people, and identify, was this the best decision that could be made? Also do some comparative analytics in terms of if you've got multiple access managers or hospital team members that are making decisions around inpatient admission, why was the decision made this way on this consumer made by this staff person? Why was it made a different way in a similar scenario with a different staff person? We're trying to look for some validity across staff people related to decisions related to inpatient admission. Then also focused on recidivism, who's in the hospital right now, who's being discharged, and we're also looking at, for one of the areas that we can do is drill down into folks that have had extended length of stays, identify those consumers as potential complex case management cases, and then approach those cases differently. If somebody's been in the hospital 8 times this year, we need to change something. They're not getting what they need. So when those come out, and especially if they're at one of the pilot hospitals, the day of discharge, which we're looking to implement at St. John's, already have in place at Henry Ford, if they're coming out of one of those hospitals and they've been in inpatient 8 times this year, we should be able to tag them, identify them when they come in on that day of discharge program and say, all right, we're going to try something different here and do some more complex case management, more intensive services to try to keep them out of the hospital. And then, as we mentioned, ensure that we have insight to all state-level KPIs. Make sure that we are making an effort to reduce any KPIs that are out of compliance. So that's what we'll be working on for the next quarter.
Great. Joan, what's the question?
Is the system in yet where, like, if our patients go to St. John's, then they go some other hospital, do they have to give their data all over again? I know they were going to try to do something in hospitals to where you know what this patient's doing if it's moved to a different hospital. Is there any tracking?
All of the hospitalizations are being tracked. And they're being tracked based on
No,
authorization.
I wondered if the hospitals aren't doing it. Yeah.
Oh, if the EMR is compatible, not at this time. And we can share information, via reports, but in terms of one EMR talking to another EMR, I mean, you've got technological concerns in terms of that exchange
Yeah,
of
because
data.
if they go in one hospital and they end up having the same treatment that they had before.
Right,
Because
right. Well,
we don't have that yet.
Well, no, we would be able to know if somebody was in one hospital and then 2 weeks later showed up in another hospital, we would know that, yes. That this data would provide that information. We would know how long they stayed.
You would know it, but does their information go with them?
To the second hospital? Typically not. I
Do
don't
they
think so.
talk to each other, the hospitals, the doctors? No? Selena's shaking her head, and I know she's in the hospital.
Well, we could ask the subject matter expert here.
Right, yes.
We do coordinate care from, if they came into an Ascension hospital and they went to a Henry Ford. We communicate with the outside psychiatrists so whoever they're seeing in an outpatient, we would communicate with them. But our EMR in Henry Ford's would not. The only thing that we can pick up is if they had been there the previous month, all that data will populate forward. So that kind of gives us an idea of what we tried the last time that maybe didn't work. But we always have access to the access managers and to the focus system. And within that would also tell us what medications they've tried, who the providers were, who touched bases. But unfortunately, at this time, the EMRs from different hospital systems do not coordinate together.
That concludes this
That
part of your.
concludes this report.
Are there any other questions from anyone else? Had some good questions, helped to understand, Linda and then Selena.
I just want to thank, Bill's not here tonight, but I want to thank staff, and I'm sure it was more than Bill, but that was involved in finding this, knowing we needed this, and bringing this to us for a contract.
Yeah, it's been a real team effort in working with the FIA, and they've been very, very willing to hear our concerns, hear our challenges, and offer potential solutions to them, either through data or through the expert. And it has been a very good relationship so far.
Selena?
We are the pilot hospital for this, the telephonic, and we're only in day 3. It just went live on Monday. But I have checked in with my staff every single day, and they love it so far. They say that it decreases about 3 hours of their time from going in the computer, filling out the form, and continuously checking it all day long to see if they kick back an answer. And then sometimes they kick back an answer and they just want more information. And that's very time consuming. So we're actually able to touch more of our patients in the hospital because we're actually talking to somebody that could say, hey, you missed this. What was that answer? So far, from the hospital side, we're actually working on, it's only a Monday through Friday from 8 to 5:30. So that's going to be able, we'll be able to compare the off hours versus the on hours. But I think that the providers will be happy with it also. So far, like I said, I'm only in day 3 of it. But it seems very positive, and all my staff are really excited by it because it's real time. And we can get a real diversion if we needed it, like now, instead of missing a bed or, something else later on in the day.
Nick?
Yeah, the agenda indicates that you're asking for an extension. When does the contract expire, and how much of an extension do you need?
Go ahead.
That was for the data report capacity that is a separate contract from this.
Oh, okay.
Yeah.
So this one, the contract is until when?
I think this goes till September 30th of next year, of 19.
Next year, and you're giving quarterly reports. Excellent.
Correct.
Quarterly report. Thank you.
Yep, thanks.
Sure.
Anyone else? Okay, do we take and receive and file? Yes. On this, all right, we need a motion then to receive and file do you have any other report?
No.
All right, the director's report. Okay, motion by Doherty, support by Birdie. All in favor signify by saying aye. Aye. Opposed? Report has been filed. And then next on the agenda is, I just wanted to give a brief overview of the conference, the State Community Mental Health Board Conference. There were 4 board members who attended, and it was Joan, Linda, Selena, and myself, and John Kinch, our director, and Amy Smolsky, one of the employees, were in attendance there. And what I really wanted to report is that a lot of talk was held at the conference about public-private partnerships. There were some just casual meetings that were held after hours and on breaks, but there was also a panel discussion that included there was a report from Kalamazoo Community Mental Health and how in their substance abuse services with Priority Health. And then there was a section 298, that pilot project. There were a few CMH counties that are on a pilot project. They reported on their progress on that. And then the third one was Lakeshore. As we know, Lakeshore is the one in Western Michigan, the PIHP in Western Michigan. And they're now partnering with Beacon Health to share some services with Beacon Health to help them to improve their bottom line number-wise. And what was interesting with that, there's 5 community mental health boards in that PIHP, and they ended up having to have 5 separate contracts because there's different services, different ways of providing services with them. So they're actually only 3 months into the operating of this, so they didn't have a whole lot to report about how there were we didn't get any metrics or any numbers to compare for them to tell us how it's working, other than how they went about with the projects and how they went about negotiating their contracts. So I just think that is something that this board may want to look at while we are in a positive situation and not backed up against the wall. We keep getting the quarterly reports, and as we know, our ability to meet the contract with our internal service fund balance could be problematic. So I would recommend, I'm going to ask John to continue talking to some of these people, perhaps bringing them in or providing opportunities for us to get some more information. Bob Sheehan also spoke at the Tri-County Breakfast, which is usually which was held the last morning of the conference. And he said too that his message was a little different from when we had the Tri-County dinner. He was telling us, about how these partnerships are available. We may want to seek them. I think part of it's his experience. He's been experiencing different things through these since the last time we met. And he also just said the time to negotiate or to look at them is when you're still doing well, not backed up against the wall. If anyone else that was there wants to add to it, yes, Selena?
The takeaway that I got was that we should, have an open mind and take a look at these things. As everybody stated, and even when, we spoke with Beacon or whoever was, pulling everybody aside to discuss it, was that right now we do still have our head above the water, and we would be remiss not to look at other options that are out there and have them tucked away in our back pocket if we do need them. I foresee us all needing at some point to probably partner with somebody. I think that it would be a good idea to start exploring it now. Well, I know that we have a transition with the CEO and all of that going on, but I think waiting until after the first of the year is too late. I think the takeaway that I was getting is that a lot of the other counties are already starting to think about it the same way, and the PIHPs and starting to partner with it. So I think that maybe we should go forward and start exploring some different options and gleaning information on what we might need to do.
Yeah, thank you. Linda?
I would just add that one thing that was a little more encouraging to me than, just a total takeover and all privatized and whatever, that they all expressed, and I, have to take them at their word for now till we explore more, but they expressed a real appreciation for the public part of the system, the local control and that kind of thing. So they're saying the words, it would be our responsibility to hold them to that. And again, I agree with Kathy and Selena that you don't want to wait until they tell you what to do, till Lansing tells you what you have to do because you're failing.
Right. Selena?
Is there a possibility, I know that Beacon has created the 5 different contracts. Meridian has theirs with the 298 pilot. They haven't even gone live with it. It's taken them, over 4 months to figure out common language and, where risk was going to be versus benefit was going to be and all that. Is it possible if we can reach out to some of them and take a look at maybe what their contracts look like? Because that might give us an idea of questions that we would need to take a look at. And it would give us an idea of, the administrative versus the piece, where does the profits end up, that we could start formulating our own questions based upon our own specific needs.
Yes, I would think being that it is public, now, the negotiation part probably was not public, but now that they have the contracts, those should be public. So I see you taking notes. Will you be bringing that back and trying to get that information? Yep, for us. Thank you. Thank you. Joan?
I like the idea that he mentioned something about go slow, and you're doing it, not slow, but really look at it and don't take the risks too fast.
Right, being deliberate about
because they're out for a profit.
Correct.
We all.
Yes.
And what was that doing that Steve said about the fox and the scorpion? He said fox was gonna cross the river, and he asked, the scorpion said, "Can I sit on your shoulder and get across?" And as the fox was going, he says, "No," at first, he says, "because you'll sting me and I'll die, you know." And he says, "Oh, no, I won't do it." So the scorpion got on his shoulder, and they started to cross the river. And in the middle of the river, the scorpion stung him. And the fox says, "I thought you weren't going to do that." And he says, "That's my nature." So he just said that an example, be careful. Be careful.
You remembered the story well. I couldn't have retold it as well as you did. Very good. Yeah. Very
Did I?
good.
Oh, and are you going to mention how much money we made on our Red Wings tickets?
Well, we didn't see the final, but the last bid that I looked at was $210. That the basket that we brought raised $210 for the pack.
And
right.
Selena's tickets were $75 a piece. And
So-
when we had the blanket, and it was
Yes.
nice.
Yep. Then one other thing, which is a positive note to me, was the final presentation that we saw was on resiliency. And I thought that was a great way to conclude the conference.
Yeah.
And Joan and I rode together, so we talked about resiliency a lot on the way home, but we need to track resiliency too, so that just the resources that some people need a different resource, and how we all have different experiences in life from which we learn to be able to pick ourselves up the next time something negative happens. You're able to use the resources you learned from the time before. And I thought that was just a great way to end the conference. And I think that's something on all levels, on our financial level, on our as we
Yeah.
serve our consumers level, as we work as employees and encounter difficulties. So that
And
was a great way to end.
what did they say about COW? You know, they used the acronym COW, the crisis of the week. When
Oh, right,
the crisis of the week, COW.
right. So, okay, that concludes my report. Do any of the other board members have any other agenda items? Chris, would you like to give an update on the?
Yeah, just a quick update. We did start interviewing for executive director last week. 4 hours of interviews last Thursday. We actually have additional 3 hours of interviewing coming up this coming Monday, and the team will debrief after, and we'll go from there.
Thank you. Anyone else?
You may ask, and I'm happy to share it individually, but not publicly. I can send you names.
That wasn't my question.
You said, may I ask who interviewed?
No, may I ask who is interviewing? Meaning
Oh,
who is conducting the interviews?
Oh, it's the executive
It's
committee.
Executive committee. That's what we talked about when we had the first,
Thank you.
Phil?
Thank you, Madam Chair. I just want this board to know that today I went up to St. Clair County and spoke to their CMH director. It was a meeting that was put on initially from Chair of the Board Bob Smith and Vice Chair Jim Carabelli to kind of go on a fact-finding mission to learn a little bit more about an authority status. So they reached out to Deb Johnson in St. Clair County, and I was tipped off to it because John Kinch was tipped off to it from Deb. So I wedged myself into the meeting. I wasn't initially invited. And lo and behold, Jim didn't show up. So it was Bob Smith, myself, Jeff Boehm, who's the chair of the board in St. Clair County, and Deb Johnson. So we had a pretty good discussion, just basic questions as to how they do things up there. She peppered me with a lot of paperwork that I would be happy to share with this board. And then I suggested too, possibly a joint meeting with our board and the Board of Commissioners, and have Deb come down or somebody come down from their CMH just to have a discussion about, how they operate as opposed to how we operate and things like that. So it was very introductory. Like I said, Chair Smith just wanted to learn a little bit more about what they do. and I figured I would tag along and report to you guys. So thank you, Madam Chair.
Well, thank you for working your way in there, because if the Board of Commissioners is talking about it, it's something this board needs to know about as well. And I guess that's part of what, a couple meetings ago, we had said, you know, everything is on the table, and we want to be able to make sure we have proper discussion and get all the information we can on anything that might affect this group. Right, anyone else? Okay, seeing no other questions or comments, then we'll go on to item 12, hearing of the public. Is there anyone from the public that would like to address this board? Please identify yourself, and you have 5 minutes.
Good evening, board. I'm Sean. I live in Macomb County. Just here to give the usual CEO update. For our individual served update, October 31st, we'll be doing Halloween parties at all of our community centers. The individual served monthly education seminar is conflict resolution. For our community center update, our Clinton location is in the process of developing a micro business to do design gift bags. Small bags are $1 or 6 for $5. Large bags are $2, 3 for $5. And I got a couple here if anyone's interested in buying them. As well, at our Anchorville location, we have updated a vehicle with replacement seats. We have explored new community activities to increase compliance with the home and community-based service ruling. Our Mount Clemens location opened a candy store on October 1st. The program has harvested the apples at our location, and individuals served were able to take them home. Our Washington location has started a new crew site at Friendship Campus Church. For our stakeholders, CO will host the Gentle Teaching Practicum on November 21st, 2nd, and 3rd at our Clinton Township Center. Also at Clinton, we will be hosting the MRS Career Counseling Seminar on November 7th. CEO has sent a total of 14 staff to the Staff Appreciation Luncheon hosted by Macomb County Provider Alliance. CO attended the Macomb County Informational Exchange on October 23rd, and our Anchorville location will host the annual vendor show November 9th, which I do have flyers for this time. Well, it depends on what you want to buy. How about see me after? That's it. Thank you.
Thank you very much, Sean. Is there anyone else from the public? Seeing none, we will move on to our last item, which is adjournment. Need a motion to adjourn. Motion by Bush, supported by Schmidt. All in favor? Any opposed? Meeting is adjourned. Thank you, everyone, for your participation.